Thank you. It's a privilege to be here again this year, and thank you so much for the organizing committee for inviting me today to talk about endovascular stent grafting for type A aortic dissection. And as Dr. Provenza just mentioned, the endovascular field in the ascending aorta is rapidly expanding, more so than I thought it would even at this point. It's still not, a regular day-to-day element of what we do, and for those of us who do open surgery on the ascending aorta, still for the vast majority of people who have ascending aneurysms or root aneurysms, we know that open surgery is extremely safe and extremely effective for that problem with a less than 1% mortality in centers of excellence. So who's really eligible for endovascular therapies in the ascending aorta? Well, there's the group of people that need a zone 0 landing zone because they have a terrible arch problem. There's the one-off, weird, unusual ascending aortic pseudoaneurysms that we treat with a stent graft once in a while. But actually the group of people who could probably benefit the most from any kind of endovascular therapy in the ascending aorta is the patient with the acute type A dissection who's malperfused or unstable or otherwise a poor candidate for surgery. And this is obviously a very high-risk scenario no matter what. So when we look at potential targets for endovascular therapy in the ascending aorta, there's three different categories, and I think Dr. Provenza went over some of this, but the ascending aorta only grafts, so that's something we're just treating the ascending without dealing with anything at the root or valvular level, and that's generally what I'm going to talk about today. There's techniques that involve replacing the ascending aorta and the valve, so as two separate components, which would be we call a wheat or an endo-wheat procedure. And then finally a full root replacement as Dr. Provenza just went over, which includes grafts into the coronaries and sealing at the annular level. So as we know, the ascending aorta, among all the different portions of the aorta, is the most hostile to place a stent graft. And you can see here from the pulsatility that there's so much up and down motion. Even at the brachiocephalic trunk, there's 3 to 4 millimeters of motion between systole and diastole. There's a rotational twist. The area of the annulus also changes significantly. And so landing stent grafts in this area is extremely hostile. And in particular, as opposed to TAVR, where we're landing in a calcified annulus, if you're landing in a non-calcified annulus, you'll probably need, if you're landing at the valvular level, something that can grasp the leaflets as opposed to something that's actually landing in the annulus. So if we look at our series of patients in whom we've used ascending stent grafts so far, predominantly it's been people like this who have these scary pulsatile, that's the pseudoaneurysm from the aorta you can see through the chest wall. And we treat them with stent grafts. I think this was maybe with a couple of TBE cuffs. But you can see how bad the apposition is. And this is the problem. There's so much curvature in the ascending aorta. Now, there's a graft in this one, so it's even worse. But there's so much curvature in the ascending aorta, it's just hard to get a coaxial deployment. And so, yeah, we've used in pseudoaneurysms, we've used in arch branch cases, but can we actually repair a type A dissection with an ascending stent graft? And Rod White and Ali Conazet have shown us that, yeah, you can. This is with the Medtronic stent graft that was basically just a regular TR graft, but a little bit shorter. And they had a series of 6 patients that they used for acute type A's. And had decent results, but you can see, again, very hard to get a good coaxial deployment down at the bottom, and these were still pretty much first-generation devices that didn't have a lot of features specific for the ascending. So then comes along the Gore graft, and this has really been the one that I think has changed our ability to intervene on the ascending aorta, and it comes in a larger variety of sizes and lengths, which is very helpful. And importantly, it has this one feature that you see also in the active control where you can really flex the device. You can see it flexes almost at its midpoint. And that's designed to fully take it to a coaxial deployment in the ascending aorta. And you can see there it lines up along the SUJ very well. So here's just some examples of, this is a pseudoaneurysm case we did with the ASG device. And again, you can see perfect apposition, totally parallel to the STJ. And a similar case that we did with other devices, I think these were TB cuffs, where you just simply cannot get that kind of coaxial alignment. So as Dr. Provenza showed, there's been a series of ARISE studies. These are with the ASG graft. And the first one was an early feasibility trial that actually looked at type A aortic dissection. And overall, there were 38 cases enrolled, of which 24 were, or rather 19 rather, were in the sort of primary arm or acute type A dissection, of which 15 received the ASG device. And I think overall, in a group of patients who are totally inoperable, having a 16% mortality and 5% stroke rate wasn't bad for people who would have certainly died anyways without therapy. And we learned a lot from that trial. We learned about sizing. So go big if you're going to put a graft in. Don't try to size to what you think the original aortic diameter was. You actually want to really push the layers of the aorta together. Use the outer curve length, so you need to go longer as well. The biggest problem I think we ran into early on was realizing that even in cases where you thought one stent graft could treat it, you actually almost always needed two. This is an example of one of our cases that we did at Penn. I did with Dr. Wong, who's here too. Essentially, we took a patient who was inoperable but had acute type A dissection, and kind of went in with this plan that we were going to do a double bypass in the neck, or in the chest rather, just opening up the sternum at the top, a little split at the top, and moving the head vessels around, placing in, the ASG graft, placing a TBE, and then extending with a straight graft. And this is just a quick summary of that case, where we've done this double debranching procedure through a little mini sternotomy, which also allows us to drain any pericardial effusion. We're just covering the entry tear here. Obviously, we're going to extend this all the way through the arch, so we don't need a full coverage of everything at this point. But we're covering the entry tear. We've deployed the first device. We're deploying the second device, the two-stage deployment. Again, we're using rapid pacing for the second stage just to nail it perfectly on the STJ. Then we're going to extend with another TVAR distally, and then we're going to finish it up with the TBE graft coming in here. So now you have a total endo arch from the STJ down to the diaphragm almost. So a total thoracic aortic repair in one stage for an acute type A dissection. And this is the patient. This was the final result here. And we actually did this case 5 years ago now, and the patient's still doing well. We ended up having to extend our innominate branch a little bit because of all the rotational motion, it actually pulled back out of the innominate. So this technology is here and now. We can treat type A dissections this way. I think we still need a little bit more data to understand what the durability of these repairs are, but as I say here, the future is amazing, and I think we're almost there already. Thank you.